So as we know, there are lots of challenges in primary care in heart failure. It's poorly identified in primary care because it can often be a complex illness to diagnose at the early stages when patients just present with minimal symptoms and signs. There's a lot of variation in timely access to diagnostics, including open access echocardiography, and often long waiting lists in heart failure clinics. We also know that there's issues with prescribing of the drugs like ACE inhibitors, angioreceptor blockers and beta blockers, which reduce the mortality and morbidity of heart failure because GPs are dealing with complex patients, often elderly, frail, with comorbidities and lots of other medications. We know that once it's been diagnosed, cardiac rehab is underutilized, and we need to do something about that. So there's certainly room for improvement, and there's room to develop more multidisciplinary teams to tackle this, which is why NICE actually recommend that all patients with suspected heart failure should be referred to a specialist for assessment and echocardiography. And we also know that in patients there's inter-individual different trajectories, so we need a holistic approach to managing those. So what we did back in Darlington in 2001 is we looked closely at how the patient flow happened from a suspected diagnosis in primary care and secondary care into heart failure clinics and diagnostics, which was part of my PhD work at the time. And a qualitative paper we looked at, looking at the barriers to accurate diagnosis and effective management of heart failure, identified three main areas. The uncertainty in clinical practice, so the diagnostic difficulty I've already mentioned, particularly in obese and elderly patients, concerns about multiple drug side effects, concerns about comorbidities and polypharmacy. The local organizational factors, so availability of diagnostics like echo, interactions with secondary care, and then the awareness of relevant research evidence in an increasingly complex area. One area we did look at in our research was using natriuretic peptides at a very early stage, and we were one of the first clinics, if not the first clinic, to use natriuretic peptides in diagnosing and investigation patients with heart failure. And we did a big meta-analysis covering over 5,000 patients using raw data from 10 different centers across the world. And we found that the main factor that affected the level of natriuretic peptides, especially NT-proBNP, was age. So we have come up with age-related cutoffs by which we use to decide whether a patient is referred into the clinic and whether they're referred within 2 weeks if it's very high or 6 weeks if it's not quite as high. So we set up a one-stop diagnostic clinic to start with. We decided that it should be based in secondary care because Darlington's a compact town and it's of about 100,000, and the hospital is bang in the middle of that, rather than basing it in primary care. That also meant that we had the backup of experienced echo technicians, secondary care consultants, my mentor, Professor Murphy, who's a general cardiologist with a heart failure interest, but I ran the clinic with heart failure nurses. They all have a clinical assessment, ECG and echo if they haven't had that done, and then we come up with a diagnosis of either heart failure with reduced ejection fraction or preserved ejection fraction or an alternative diagnosis. If they have heart failure, then we work up a management plan, educate the patient and their carer, and we're able to then follow them up in initiating evidence-based therapies, and we're able to refer into other diagnostics like cardiac MRI, which we're using more and more to look at the cause or etiology of the heart failure into cardiac rehabilitation and back out to primary care when the patient's stable. Our heart failure clinic diagnostic template looks very complex, and it is when it comes to heart failure with preserved ejection fraction. It's simpler with reduced ejection fraction, but this is up there to emphasize how complex it is and why we agree that patients should be referred into a specialist heart failure assessment service, as NICE says, but our main aim is to come up with a diagnosis and the etiology and then an individual management plan. And it's good to see that GPs are using the natriuretic peptides well in deciding when to investigate patients and referring them into our clinic, because the uptake of that clinic, 56% of patients referred in have heart failure with reduced ejection fraction, 11% with preserved ejection fraction, and that suggests, because that's much higher than previous figures, which are around 25 to 30% before we used natriuretic peptides, that natriuretic peptides and GP's understanding of them locally, largely due to education, has resulted in the right patients being referred to the right clinic at the right time to the right person. We still know that the prognosis of heart failure is poor. That was emphasized more recently in a paper by Claire Taylor. So we still have a lot of work to do. The average age of diagnosis of our patients was 77, and 70% of those with reduced ejection fraction will have died at 10 years, and 40% only in the preserved ejection fraction group will be alive. So 60% of those will have died. So it's still a high mortality, high morbidity condition, and we've got a lot more work to do. We have a good integrated service, and you'll see from this algorithm that we accept patients from primary care, but we also pick them up from geriatric wards, inpatient wards, and take them from elderly care clinics as well. We then assess them, and we can then refer them into specialists, other specialists, tertiary care services if they need revascularization, a defibrillator or cardiac resynchronization pacing, palliative care and cardiac rehab. So we have a integrated, seamless, joined up service across primary, secondary and tertiary care. And what we do need to do is we need GPs now to be more aware of clinically assessing these patients face to face. NICE guidelines say that should be every 6 months. The new QOF indicators, which are under discussion for heart failure, will say that that should be annual with a functional capacity assessment, which will be based on New York Heart Association classification, so we can then decide whether patients need optimization or escalation of their medical or device therapy. And it's really gratifying to see that the work we've done in Darlington CCG in upskilling primary care clinicians, having a CVD lead GP and nurse in every practice has meant that we sit at the top of the table in getting patients onto ACE inhibitors and beta blockers, which we know are a good surrogate marker for improving mortality and morbidity. But we've still got a lot of work to do in heart failure, and we need joined up services.